you whisper in my ear the things you wanna feel? I give you anything to feel it coming. Do you wake up alone and wonder where you are? Forgiveness all your faults. I wanna wake up where you are. I won't say anything at all, so I don't slide. Yeah, let it slide. Don't you love the life you should? Faces on the phone, the father hit the wall. Your mother's on you. Don't suppose I'll ever know. Needs to be a man, something I can say. I live around here. I wanna wake up where you are. I won't say anything at all. So I don't slide. And I'll do anything you ever do. Complete little piece of nothing but all. Put your arms around me. What you feel is what you are. What you are, beautiful. Wanna get married? Run away.
Good morning, everyone. It's like John starting us off with a little joke. I got a chuckle. I appreciate that. I'm a sucker for a dad joke or a bad joke, so I appreciate that a whole lot. And we need more laughter in the world. I firmly believe that. So, all right. So I think when you guys go into Zoom to click into class, there's two links, right? You see two? Click the first one, always. I can't delete it. I tried deleting it. The second one, it duplicated. And when I delete one, they both go away. So just always click the first one that pops up. So I'm going to give it a few minutes to let others know because we are missing quite a few yet. Let's see. Any outline, questions, concerns, anything? Anything we're not feeling good about? Questions on the homework? Okay. I shared this with the group yesterday. I should probably post this in an announcement too. If you need help with referencing formatting, the Purdue OWL Online Writing Lab is a wonderful resource. This assignment that's due on Sunday is meant for you to format things properly. Things are different from 6th edition to 7th edition. I have my trusty book with me, like right next to me. I'm looking at spacing, I'm looking at italics, proper formatting, hanging indents, all that kind of stuff. I don't need a title page. I don't even care if there's a number in the upper right-hand corner. Start your page, references, bolded, centered, and then go from there. Alphabetical, and then the proper formatting like you would do on a paper. That's it. So if you have questions, just reach out to me and let me know. But hopefully that website can help you if you don't have access to the APA book.
So I did have a question about that.
Okay.
Is it just 3 random things, or do they need to be related to another project we're doing? Or
Nope, just 3 random ones.
okay,
You could do the textbooks for this class. You could do Google CPR and see what pops up from Mayo or Hopkins or whatever, and then look at an old reference page, journal article you use for another class and use that. Like, work smart, not hard. This isn't meant to stress you guys out. So just one second. All right. Okay. Well then, few more things. Let's see.
Professor, I had a question.
Yeah, go ahead.
So I was like browsing through the pre-lecture video from Dr. K, and then I was cross-referencing it with like the topics under this week's module. And there were like a lot more disease processes on the Dr. K presentation versus like the topics that are listed, but are all of them that are on the PowerPoint fair game, or is it only like the focused ones under the module?
I would say, well, let me look at what you're talking about first of all, because I'm not sure. I don't want to tell you the wrong.
Oh,
thing.
sure. Yeah. I just went into like modules week 2, and it's just like learning under the home tab. It will say learning objectives and then topics. And it had like, 7 upper and lower respiratory diseases.
Let me see here. Modules, week 2. Asthma, COPD, TB, all the stuff we talk about in class.
Okay, just because on the it had like laryngitis and
yeah, we talk about that in class this week.
Okay, thank you.
His recordings are basically voiceover PowerPoints of what we go over, but again, it's more from a medical perspective and not so much the nursing cares. So it's a different perspective, but it's not required. It's just an additional resource, especially if you review with like patho and A&P and that sort of stuff. So, and they're long. They are long.
They're long.
I think This week's or last week's was like 4 hours, and I'm like, good Lord, that's a lot. So, okay, I'm just answering a few emails real quick with some issues with the Zoom. Oops. Just trying to get everybody here. Are you guys having issues with Zoom and any other courses? Just mine?
No, in OB, I can't get in on the link that she posted in announcements. So I have to go like on the side tab and go to Zoom and then another page and open it. And that's the same thing I do for this class.
Yeah, that's how it's set up, and that's how we're supposed to set it up, is you just use the Zoom tab in Canvas, because then we don't have to post each week and clog up the announcements. But for whatever reason, when we created it, first something happened where they all disappeared, like all of our meetings disappeared, and then I sent a ticket to IT and they put them back in, but then they duplicated it. So then there was 2 meetings for each day. And then last week I had an issue with my Friday group where I was in one and they were in another. But even though the Zoom ID is the same, they're like, we're waiting in the waiting room. I'm like, I'm sitting here and nobody's here.
That's the same thing that's been happening in my OB class.
Okay, yeah.
It's the
So I
same
put the
exact
first-
link and everything, and it just has
Yeah,
two.
so I don't know what happened when they transitioned like all their domains and stuff from one name to the next, but something happened. Okay. Well, I'm glad you guys are here. We got almost everybody, so that's a good start. What did I want to follow up with? I'm gonna post probably in the next day or two. We're already thinking about exam number 1. So next week I'm gonna host an exam review. So details about that will be coming out. If you can't attend the review, it'll be posted just like how I post the classes on YouTube, so you'll have access to it. And then remember, exam 1 is either going to be Tuesday or Wednesday after Memorial Day, because we're closed, campus is closed on Monday. So Tuesday, 10 a.m., 6 p.m., Wednesday, 8 a.m., 6 p.m., and then all the other exams will be Monday, Tuesday instead. So we're already thinking about the first exam. And then I've talked, I know, I don't know where my list is. There's a bunch of you in this group that are going to Honduras or Guatemala. Information regarding assignments and dates will be forthcoming. We just had a whole bunch of people start and we're trying to get everybody situated, and we got a little bit of time for that. So communication about the dates for that will be coming out this week as well. Alrighty, any other questions, concerns? We good? Maybe. All right then. As always, feel free to reach out to me. If I missed an email from you this week, please shoot me another one and let me know. I tried to catch up. I like got a lot of messages last week, and I thought I got back to everybody, but I want to make sure I didn't miss anyone. So if there's something I didn't address, please let me know. All right, so we're going to jump into upper and lower respiratory disorders today. This is building off of what we talked about last week. So first thing we're going to talk about are precautions. You guys have seen precautions. You've probably donned and doffed plenty of PPE already, even as nursing students. But it's important to understand what diseases we would use with which precautions, or we would expect. We all know we treat everyone with standard precautions. We wear gloves if we're going to touch anything that could be drippable or icky. But with certain contagions, we would dictate what kind of PPE we would need to wear. So contact precautions are probably one of the most common ones that we would see. We use this for anything that basically we don't want to get on our person and then easily spread to someone else. Rashes seem innocuous enough, but we don't want to touch a rash because we don't know how contagious it is. Anybody have poison ivy? You don't have to raise your hand, but you know how just like itching something can make it spread, and touching it in contact, we don't want to spread that to someone else. So even though a rash seems harmless enough, it could be very, very contagious. MRSA is another disease that we would use contact precautions for, which oddly enough, like 80% of us have MRSA in our ears. It's some really high number. But that's more if we're concerned about like weeping wounds or anything like that. Our diarrheal diseases, so that would be what?
C. diff.
C. diff is one. Anything else you can think of with the poop?
IBS and stuff isn't a diarrheal disease, but it can cause that, right?
It can, and it wouldn't be, it's not contagious. So it wouldn't be something we'd have to use precautions for, but something like the norovirus, which is really easily spread, is something else that would be in contact as well. Again, anything you don't want on you or to spread to someone else. RSV is an interesting one because RSV is a respiratory disease, and I think we usually associate it with children because they are the most common ones to get RSV, or even some of the elderly that are immunocompromised. So RSV is one of those ones that could be contact, could be droplet, depending on the facility. So don't get too worked up on that one. Mostly because we know how spit travels, right? It can get all over anywhere. And if somebody who has RSV and you're touching them, that disease can be on you, and then we could transfer it to someone else. So RSV is one of those borderline ones that really will depend on the facility. When I worked at Children's Hospital or did my clinical rotations and stuff, RSV was a droplet, but some people wore gowns with droplet. So it truly depends on the requirements. So contact precautions, hand hygiene with always, gloves and a gown. Droplet precautions is going to be a mask and then gloves and a gown. How many times do you see people wear a gown with droplet precautions? I don't really. Usually it's just the mask, especially like pneumonia. Certain pneumonias will be in droplet precautions, or influenza. I don't see people wearing gowns. They should, but they don't, just because it's easily spread. With the droplet precautions, there's a lot of diseases that hopefully you never have to see, like mumps, pertussis, and rubella, because we have immunizations for these. Yeah, Ethan.
Sorry, I was just curious about the use of the word plague. Like, plague isn't a disease, right? It's just like a group of stuff.
It depends on what part of the world you're in.
Okay.
But mumps, pertussis, rubella, we have immunizations for, but we are seeing an increase, and meningitis too. We're seeing an increase in these diseases as more and more people aren't vaccinating their children, which can be catastrophic for other people as well. Airborne precautions is one that is, I think it's the most serious because it's so tiny and so easily spread. So TB is one of the most contagious diseases that are out there. Like the itty bitty little spittle, it just flies and goes and is very easily spread. Chickenpox, smallpox, and measles are also what we would put in airborne precautions. So with airborne precautions, they need to be in a negative pressure room, which cycles the air repeatedly and then dumps it out, and so it doesn't like infect the whole hospital. And then the N95 mask, which could be, the one that looks like the painter mask or the duckbill, something like that. Anthrax is also something that would be in airborne precautions. So hopefully you never have to be in a scenario where you're taking care of somebody that's been exposed to anthrax. So, but with bioterrorism and whatnot, it's something that we have to be cognizant of and aware. So, moral of the story, contact, hand hygiene, gloves, and a gown. Droplet, hand hygiene, gloves, mask, gown. Airborne, N95, specialized filtration. And going from there. Oh boy, you know what I didn't do? I didn't upload our poll questions for today. No, I failed. All right, well, I'll ask them and well, here, let me see how I can do this. I got so caught up in grading stuff, I forgot to do it. All right, well, I'm gonna have to skip that for right now. Maybe I can add them in a break. All right. So acute respiratory or questions on precautions. You guys probably feel good about that. The key to also with precautions, I should probably mention, is making sure that you are aware of what you need when you need it. So if once you put everything on, you don't want to have to leave the room, because if you have to leave the room, you have to take everything back off and put everything back on. I told my group yesterday, I had a group of nursing students. It was their first clinical. We were in LTAC, and I assigned 2 patients to 2 nurses in the same room, but they were in contact precautions for a rule out C. diff. One was sick, but because the person's in the room, they're both in there. So they're going over their plan of care with me, telling me what they're gonna do. They're like, okay, we're gonna, get them, bathe them and get them dressed and get them, situated for breakfast because they had to stay in their room. So they put on all their PPE and they go into the room, and then they realize that they don't have soap and they don't have washcloths. And they're like, so what should we do? And I said, you need to take your stuff off and you need to go get it. And they're like, well, can't you go get it? No. It's you learned now, didn't you? Make sure you have everything you need before you go in there. It's not me being mean. I can easily go get it, but you're not going to learn, and now you're not going to forget. So plan ahead, make sure you have everything you need, or call for help. All right, so acute respiratory disorders. These are, I think, really easy to wrap your head around because you've probably had at least 2 out of 3 of these at some point, okay? Laryngitis is inflammation of the larynx. Ever go to a sporting event or a concert and the next day you sound like a little squeaker? That's what this is. Laryngitis is usually caused by overuse or in some instances, a viral infection. What we would expect to find with laryngitis is hoarseness, like a tickle in the throat. Aphonia means losing their voice, like they can't speak, and a cough. Again, usually this is self-induced and it's self-limiting. What we really do with laryngitis is we tell patients, you need to be quiet, rest that voice. Humidity is very, very helpful. So like steam can help. Not smoking. Smoking will irritate. And then actually, it's important that we educate patients that really, really cold can be irritating. So to avoid like Arctic air or really cold fluids. Again, only in certain cases would we treat this with an antibiotic, and that would have to be like a bacterial in nature, which would require much more tests. It's incredibly rare. Again, rest, humidity is really what's going to be at the forefront here. Laryngitis can also be caused by GERD, which is like acid reflux, which we get into in a few weeks. So that is something we keep in the back of our mind as well. And then for chronic laryngitis, chronic issues, they could be prescribed some steroids to help with the inflammation. Again, generally this is self-limiting. There's not a whole lot we do for it, but in serious cases, we have to be aware that this could cause an airway obstruction. So if we look at what we have going on here, this is your normal airway in your larynx that will move with vibrations, and that's how sounds are made. But with the inflammation, it's a lot more narrow. So it can be very difficult to move air. But again, that's with very severe cases. Generally, you won't see that. The flu. The flu is like one of the worst things you can ever experience as being sick. You know, if you've had it, you know what it feels like. You feel like you got hit by a truck. Everything hurts. It hurts to blink. Your hair hurts. You have no energy. So we tend to understand it a little bit more because most of us have experienced it at least once in our lives. The flu has a season. Okay, we vaccinate, and peak flu season is September 1st to the end of April. So we are officially past flu season. Yay. That doesn't mean that we're not going to still see it. Okay, the cases are highest in that amount in that seasonal time. With the flu, it's important to know which we do. It is very, very contagious. You are contagious 24 hours before symptoms start showing and 5 days after you've had symptoms. So that's a good chunk of time. We also have pandemic flus. I don't know how many of you guys remember the bird flu and the swine flu of like the 90s and the late 2000s, but this H1N1 was in the late 2000s. And it really wrecked a lot of people, a lot of vomiting, a lot of different diseases. But what happens with those flus is that they are mutated viruses that became infectious to humans. So generally, things that affect our pets or animals don't always affect us. But if it's one thing we've learned from COVID is that these viruses are smart, they mutate, they transform, and they're going to make themselves adaptable to infect hosts. And that's what we've seen happen with this. So, we do have this question, which is super helpful. So you guys can throw that into the chat. All right, great. Lots of A's. Absolutely. So this is one of those instances where like, yeah, we'd want to do like all these things, but which one is going to be the most important? Well, we can't do anything without getting those vitals in that O2 saturation. So absolutely. When we're assessing someone with the flu, we expect them to have significant headaches, muscle aches, fever and chills, those are rigors, okay? Weakness, and then with some of the bird flu, they'll have more diarrhea, cough, and oxygenation issues. We diagnose the flu with a flu swab. Anyone ever have a flu swab done? They're pretty awful. They go way up in there. Same thing. It's like, I think it's worse than the COVID swab, but I don't know. Dig up in there, get that nasopharyngeal, and they send it off. Or you can do a rapid test in some of like urgent cares and things along that line, and they'll test for influenza A or B. In terms of interventions for the flu, maintaining our droplet and contact precautions, because we want to prevent the spread. Monitoring their hydration status. When you feel like crap and you can't move and you don't want to do anything, you're less likely to eat and drink the way that you're supposed to. You don't want to get out of bed. You don't want to do anything. You don't want to have to get up to go to the bathroom. So patients that are ill are at risk for dehydration. So we need to make sure that they're monitoring their eyes and nose, and that if they're drinking things, that they're drinking quality drinks. Okay. We always talk about like, let's increase their liquids, but I want you to make sure that you're clear on what the liquids should be. 2 liters of water a day and a 2 liter of soda a day are 2 very different things. So make sure that with our flu patients that we are also monitoring their respiratory status. Typically, patients that are hospitalized with the flu are in a bad way. Most people with the flu can treat themselves at home and they're fine. But if they have to be hospitalized, generally there's something else going on. So we have to be on the lookout for that. We can potentially treat, I don't want to say treat the flu, help the flu with giving them Tamiflu. Tamiflu is an antiviral that can help shorten the lifespan of the flu virus. The problem with Tamiflu, there's a couple. One, it's expensive. Two, we have a very short window in which we can administer it for it to be effective. Tamiflu needs to be given within 48 hours of symptoms starting. Most people don't go get tested till they're past that. So it may not work. Other interventions is still administering flu vaccines and also providing patient education. So flu vaccines, we push, even if they've had the flu, we want to vaccinate them because it helps reduce the likelihood of being infected with other flu strains. It's impossible to know because, again, viruses are so smart, but they help reduce either the likelihood of being infected or shortening the lifespan of that should they come in contact with that. Remember, vaccines introduce antibodies into the body. By introducing these, the antigens, antibodies are created, which tells your body how to fight the virus. This is how they work. So we want to reduce infection as much as possible. And that is one way that we can do that. Click, we're not gonna click, there we go. In addition to teaching them about vaccinations, hand hygiene, and cough etiquette. What do I mean by cough etiquette?
Like covering your mouth when you cough? Is that what you're talking about?
Yeah,
Or-
cough it up to their elbow, not on someone, washing our hands, turning away, that sort of thing. I like to joke that I think one of the best things that came out of COVID was the ability to be like, back up, like give me space. I don't like people near me. I just don't. So I feel like social distancing kind of helped with that. I can back away and not come across as rude as I can be. So social distancing is important when we're sick with anything. Germs fly, okay? You ever watch somebody blow out candles on a birthday cake? Especially little kids. It's like the most disgusting thing ever. But even when you talk, the amount of spittle that sprays, like space matters, okay? It is also important in terms of education that people know if you are having flu symptoms, increase your fluids. We want you to stay hydrated, stay home and rest. People like to try to push through and go to work sick, and it really doesn't do anything except put others at risk. So we want people to stay home. Additionally, we want to avoid travel where pandemic flu is going on. So make sure that if you're planning any trips, look around their area and see, do they have anything going on? Remember the Zika virus where everything like shut down in the Caribbean because it was infecting people, or bird flu, anything like that. So if you're going somewhere more exotic, you are more at risk for developing an infection because we're not from there. Remembering signs and symptoms of the flu: headache, fever, sweat, rigors, achy joints, extreme tiredness, a lot of coughing. There may be some vomiting associated with the flu. A lot of times that has to do from coughing so much, like it just forces its way out. But typically vomiting is more associated with a stomach virus or a stomach bug versus the flu. But all right, let's throw this question in here. Oh. Yep, more A's. Wash your hands. All right. So other things that we need to be considering when we're talking about respiratory disorders, especially with the older adults, is that the older you get, the more likely you are to develop serious consequences. Meaning, we have increased illnesses as we get older. So if you were to get the flu, chances are you'd be okay. Someone that has multiple diseases and is like 94 years old, the flu could kill them. So the more sick you are with other medical conditions, the more likelihood that respiratory disorders could be catastrophic. We have to be careful with the medications that we give older patients. And we know this. As we age, metabolism can slow down, our creatinine clearance can slow down, and we don't clear drugs out the way that we're supposed to. So something like Benadryl is great for allergies, great for helping clear stuff up, but at the same time, it's harder to get out. So we can see prolonged side effects with that, and increased confusion. So we have to be careful with the medications. Are they acceptable for older patients? Yep, and that's that. All right. So cruising right along to pneumonia. Pneumonia is one of those things that we may or may not have had it at one point in our life. We see it more as they get older, as patients get older too. But pneumonia is it's a response, okay? It's an inflammatory response. It got exposed to something, inflammation occurs, okay? And because that inflammation is occurring, fluid is being produced and it fills the alveoli. If there's fluid in the alveoli, we're going to hear crackles, okay? And it's going to make it more difficult to breathe. So pneumonia is an infection that causes fluid to fill the alveoli in the lungs. With pneumonia, we can expect certain things. The crackles, anxiety, fatigue, a little bit of chest discomfort because it's really trying to work, you're working harder to breathe, you got all this fluid in there. And then we can also see some confusion, especially with our older patients, and that's because of hypoxia. They're not oxygenating well enough to the brain, and we're going to have some of those very odd statements that could be made or have not sure what's really going on. Physically, you can expect things like fever, chills, sweating, shortness of breath, tachypnea. They're going to have a rapid respiratory rate because they're really working to breathe. They're literally working through fluid to try to breathe well. A dead giveaway of pneumonia is like a green sputum production. Dark yellow, green leans towards infectious. So we would see that. And a lot of coughing. So again, pneumonia is one of those things that is really, really common. The issue with pneumonia is that it could be viral, meaning a virus caused it, and it's going to be more self-limiting. That's like that walking pneumonia you've probably heard about. Bacterial, which is probably the most common. Fungal, which is severe. So there's many different kinds of pneumonia. We'd have to run some tests to figure out which kind it is, but the symptoms are all going to be very, very similar. So sputum collection is going to be huge with pneumonia. In addition to there being different organisms that cause pneumonia, we have two groups. We have community-acquired pneumonia, and we have hospital-acquired pneumonia. Community-acquired pneumonia means you caught it outside of the hospital. It happened from being who knows where, whatever's going on, but it didn't happen as a result of being hospitalized. Hospital-acquired pneumonia happens when you are in the hospital. If you're there for a week, let's say you were there for surgery, you were totally fine. 3 days later, you develop pneumonia. It is a hospital-acquired infection. You got it by being in the hospital. The ventilator-acquired pneumonia that we talked about last week, that is an example of HCAP, healthcare-acquired pneumonia. Definitely something that we would want to prevent. We can prevent hospital-acquired pneumonia. Incentive spirometry, cough and deep breathing, ambulation, hand hygiene, that sort of thing. With jumping back that last bullet point, with community acquired pneumonia, you may or may not need to be hospitalized with this. It depends on how severely sick you are. Again, it may affect others more drastically than others. To diagnose pneumonia, one of the big things that we do is we look at a chest x-ray. So a normal lung will be nice and on x-ray, nice and black. We can kind of see what's going on here. We have good oxygenation. With an infected lung, infection or fluid comes as clear. And you can clearly see that we have some upper right lobe infiltrates. That's what that means. We got patchiness spreading down, but we can't see. We got something going on here. You don't need to know how to interpret an x-ray, but it should look like this. And instead we have this. So I'm telling you, that just means there's fluid. We also need to make sure that we are obtaining sputum cultures. Obtaining cultures before we administer antibiotics is key. Other things that we can do, let's get a CBC. We're going to have an elevated white count. Shocker, we have an infection. That sounds like that would make sense. And then an ABG is another lab that can potentially be done. Not everybody that has pneumonia is going to have an ABG, but if we are concerned about oxygenation, there's indications that they're becoming hypoxic, then absolutely. Remember that ABG is that most accurate respiratory assessment that we have. Additionally, electrolytes, they tell us if they're dehydrated. Remember, if you're sick, you're probably not drinking as well, so you're at high risk for dehydration, which can traumatize the body and delay healing. And then pulse ox. Let's watch that oxygenation level. So let's discuss this one. This is a great question. Ooh, I like it. We are kind of, we are going to have a good discussion with this. All right. So who is at risk for developing pneumonia? Client A, who has dysphagia. Absolutely. They can aspirate, develop aspiration pneumonia. They would be at risk. Anybody who has difficulty swallowing is at risk for developing pneumonia. So yes. B, a client who has AIDS. 100%. They're at high risk for opportunistic infections. Especially with AIDS, they're more at risk for developing like a fungal pneumonia or a pneumocystic pneumonia. So very, very high risk. C, someone who was vaccinated for pneumococcus and influenza 6 months ago. No, they're at low risk. They would be a low risk patient. So nope. D, client who is post-operative and has received local anesthesia. Yes or no? I see yeses and I see nos. I'm going to tell you that it's no. The reason being why they are not at risk, there's one key word that makes it not be true.
Local anesthetic.
Local.
Local. So that does not indicate that they have been anesthetized like general anesthesia. If it said general, yes, but local means no. You could say, okay, well, it says he's post-op. Post-op is a general term. It could mean anything. Removing a hangnail is post-op. They have to numb you, they have to cut your toe open and get that out and suture it. That is, technically post-op. But the whole thing isn't correct. Half is correct. So if one part of it is wrong, the whole thing is wrong. So good. Closed head injury, receiving mechanical ventilation, absolutely yes. And then myasthenia gravis, they are also at risk for pneumonia. So A, B, E, and F are your correct answers here. So good job. Okay, nursing interventions for the pneumonia. Let's watch their oxygenation status. Give them oxygen if needed. Look at their sputum. Sorry, you got to get up close personal with these bodily fluids. We can watch trends and see how things are changing. If they're coughing stuff up, we want to know, is it thinner? Is it thicker? Has it changed color? Is there blood in it now? So we have to make sure that we're assessing their sputum production and what they're expectorating. We may need to help with suctioning, give them a Yankauer, helping get those secretions out and also monitoring those vital signs. Remember, if we're having oxygenation issues, we're not only going to see a decrease in their pulse ox, but we may see a high heart rate. So let's make sure that we're watching those. Your textbook uses this mnemonic I cough for interventions that should be done with somebody with pneumonia, or typically, honestly, anybody that's like post-op and we're concerned about developing atelectasis with. Incentive spirometry, making sure that they're using that tool to help exercise their lungs, increase oxygenation and flow. Cough and deep breathing. Guys, cough and deep breathing is the easiest intervention and thing that we can do to encourage movement of air and clearing of secretions. Oral care is a big one. Brush your teeth. So much bacteria and stuff could live in the mouth and puts you at risk for infection. Understanding is another one. And this isn't just the patient understanding the disease and what we're doing, but also the staff as well. How many of you guys have seen somebody just completely disregard the precaution sign? Like they're supposed to be in contact precautions and they don't put on their PPE. It happens. In an emergency, I get it, but people are like, it's fine, I don't care. Well, you're putting people at risk for other diseases. So it's important for family members to understand too. Yes, it's uncomfortable sitting there in a gown. I know it's hot. You don't want to get sick either. Also, we also don't want to introduce opportunistic new infections. So getting out of bed. We want you ambulating, we want you moving. Sitting stagnant is just, it's not going to allow things to move. It allows things to settle, and then that can create more infection as well. And not laying flat. We really want patients to be at a semi-Fowler's or a high Fowler's position if they can tolerate it. Laying flat makes it more difficult to breathe and allows things to settle and not clear out as easily. The other thing that we can also see needs to be done is making sure that they're eating and drinking appropriately. Okay. Again, when you don't feel good, it's usually one of the last things on your mind, but you need nutrition to help fight the infection. You need it for energy. Your body needs calories, to breathe. So we have to make sure that they're getting adequate nutrition, or at least calories in taking. Additionally, fluids. Fluids help thin secretions, which makes them easier to remove. So we really want to encourage their water intake when we're concerned about these things. And then making sure that they are getting their medications, whichever they may be. Depending on the type of infection that they have, their medications may differ. For a bacterial pneumonia, things like penicillin or cephalosporins are very common antibiotics that are given to help fight the bacterial infection. If you are administering antibiotics, what teaching would you want to provide to your patient?
Make sure you
Finish the
take it the
whole
same
course.
time every day.
Okay, so same time every day. What else?
Complete the treatment.
Complete the treatment. Just because you're feeling better doesn't mean we stop it. Okay, good.
GI upset.
What about it?
Antibiotics can just cause GI upset. You may have like diarrhea, you may have gastric bleeding.
Okay, so we want to tell patients, this might give you the poops, and if it does, you need to tell me. Antibiotics don't discriminate. They're at high risk for developing C. diff. Okay, so it'll wipe out the good and the bad bacteria, and then they're in, peeing out of their butt. They have to tell us so we can test them because C. diff is so contagious. So if you develop diarrhea, you need to let me know. Complete the whole thing. What else? We said same time every day, the GI issues. Anything else we'd be concerned about with antibiotics? What about allergies?
Depending on the antibiotic, you would think about the specific adverse effects like otitis and stuff like that.
Okay, so knowing your side effects, absolutely. Allergies, specifically ones that are life-threatening like anaphylaxis, they can occur even if you've had the dose a couple of times. So we want to make sure if you develop any shortness of breath, pain in your chest, difficulty breathing, let us know right away. Okay. We also give antibiotics, like as we mentioned, after we've gotten cultures completed. Bronchodilators or inhalers are other medications that are used to help with pneumonia, to help open up alveoli, which are going to be filled with fluid so we can breathe better. So making sure that they understand how to take the meds. And then in the event that maybe they're having a lot of inflammatory issues as well, steroids can be given. Teaching key points for steroids. What would you want patients to know?
Take with food.
Okay.
Insomnia,
Yeah.
roid rage.
Guys, roid rage is a real thing. I don't know if you've ever
Gain.
been on prednisone, but I was on it once and I was a hag from hell. It was bad. Everything bothered me. I was up all night. I ate everything. Everything annoyed me. Like my temper was out of control. Like I'm pretty cranky to begin with, but this was like to the nth degree. So they may experience some mood swings. A nice way to put it.
Weight gain and moon face, especially with prednisone long term.
Yeah. So if they're on a short burst, like for a week, we typically don't see that, but long term absolutely is a big issue. And we're also concerned about blood sugar. We have to watch their blood sugar, specifically if they're diabetic. So
They need to taper down and off the dose. They can't just like stop taking it. Like they go to like half, then a quarter, and
yep. All important things that they would need to know. So, all right, other education aside from the meds, fluid, at least 3 liters of fluid a day. And again, I say fluid, I mean water, okay? Again, 3 liters of water is way different than 3 liters of Kool-Aid or something, or 3 liters of beer or whatever, but people will fight you and be like, well, yeah, it's a liquid. I'm serious, they will. Remembering the eye cough. Also, not overexerting yourself. We want you moving, but we don't, if you're tired, rest. Okay, you're filled with fluid. You're basically drowning inside. We want to clear it, but we also need to make sure that we're safe and not overdoing it. Avoiding crowded areas, so concerts, festivals, that sort of thing. You need space, room to breathe. You are still at risk for developing infection, so there you go. Also, not smoking. Smoking is a big thing. It causes vasoconstriction, it causes collapse. So if we are having issues with our lungs full of fluid, smoking isn't going to help this or help your breathing in any way, shape, or form. All right. One more question here. Okay, so yep, the first thing we're going to do is administer that oxygen therapy. We want to do that first. 91% is definitely, it's on the border, but they have a respiration rate of 30, which means they're really working to breathe. So let's give them that oxygen. Then we can get a sputum culture. Once we get that culture, we can give antibiotics, and then we can get them, instruct them about their immunizations. So, all right, good, good, good. All right, this is a good spot to take our first break. I'm going to see if I can get those poll questions loaded up for you guys. So we are at 10:51. Let's come back at 11:05.
Don't cry, don't raise your eyes. It's only teenage wasteland. Gotta take my It's tearing up my heart when I'm with you. And when we are apart, I feel it too. And no matter what I do, I feel the pain with or without you. Baby, I understand just how we can
I'm back, guys. So, good news is I was able to get our poll questions back. So let's play catch up real quick and do a couple of those to see how well you retained. All right. Do. Boom. First one. All right. I don't know how I spelled tuberculosis, but that was interesting. All right. So, which disease would you need to implement droplet precautions? And that is going to be influenza, meningitis, and strep. TB, varicella, and anthrax is going to be airborne. MRSA, C. diff, and RSV is going to be contact. So, and what was polling question 2? The third one. Hey, you stop that. Oh. All right, a few more seconds here. This is a great one. And the correct answer is all of them. We would want to do all these things to decrease the spread. And we didn't get to 3 yet, so good. All right. So now we're going to jump into asthma. So asthma is one of the most significant and popular is the wrong word, common diseases that you will see in a medical history or something that affects someone. What asthma is at its core is it's a response that causes edema and thickening of the airways, making it difficult to breathe. Different triggers can trigger attacks, but at its core, it's that we are having issues with breathing. So here you can see a normal airway, nice, smooth, relaxed muscles, nice and open. Air is going to move through pretty well. With asthma, the wall gets thickened and inflamed over time. And additionally, during an attack, it's going to narrow even more, and we're going to have collapse of things, and things aren't going to move through. So with asthma, one of the big key hallmark assessment findings is wheezing. And the reason that the wheezing is occurring is because look at this airway. Air has to get through that teeny tiny little hole compared to a nice open airway. So that wheezing sound is because it's trying to force its way through. Other things that we're going to see with asthma is going to be that dyspnea or shortness of breath, coughing, increased mucus production, and then usage of accessory muscles and a prolonged exhalation. They're really breathing to get air off. Use of accessory muscles or intercostal retractions is a sign that something is really, really wrong, okay? If we are seeing the muscles working to make them breathe, it's only a matter of time before it poops out and we have a bigger problem. So if you are seeing use of accessory muscles, that's a problem. When somebody is coming in with an exacerbation, or having an exacerbation, there's important things that we need to know. When did it start? We need to know when it started, because if it's been going on for a long period of time, the longer it goes on, the more that they're working, the quicker they're going to poop out. So we have to know when it started. We need to know what they were doing beforehand. And that all comes down to triggers. Were they outside? Were they working in a cold, damp area? Did they exposed to perfume? But what was going on when it was happening? Additionally, what medications do they take and have they taken? We don't want to overdose someone, but it's important to know what they took before we got to them. And then it's important for us to know what has worked in the past for their asthma attacks. With asthma, come back here. We diagnose this through a couple of different ways, and we do certain tests when someone's having an asthma flare. ABGs is a big one. Shocker, right? With asthma, we are going to have a low O2 level. Okay, that makes sense. They can't breathe well. In the beginning, they're going to have a low CO2 level. And then further on in the attack, they're going to have a high CO2 level. It starts low because you're breathing in and breathing out, breathing in and breathing out. You're hyperventilating. But as you're breathing out, you're not blowing off all the CO2. So it's a little bit's going to stick around, and a little bit's going to stick around, and build and build and build. So initially we have a low CO2, and then later on we're going to have a higher CO2 because it wasn't able to get everything off. We also would do things like a sputum culture to find out if it's an infection causing the trigger, like the asthma attack. PFTs are pulmonary function tests to see what's going on, how well they're breathing, and what's happening. And then a chest X-ray. We want to see what's going on with the lungs, with inflating and trapping of air, and if there's something else causing the issue. What are you going to do with someone having an asthma attack? One of the big things that we always tell you when somebody's not breathing is to sit them up, right? It opens up their airway, helps them breathe a little bit better. With asthma, the alveoli have collapsed. So really we can sit them up and that's great. But what we really need is to get those alveoli back open. And what's going to happen? How is that going to happen? Through medications. We need to treat them with their albuterol and their nebulizer or whatever. Get that going to help force those back open. So anybody who's having an asthma attack needs to be on a cardiac monitor. Heart and lungs go hand in hand, so we need to see what's going on. Are they having any type of cardiac rhythm issues as well? And then making sure that we are ourselves staying calm and helping them stay calm. If you can't breathe, you freak out. Anxiety is a very real thing. It makes sense. I don't know how many of you guys have kids or have been around kids. When a kid falls down, 9 times out of 10, they get up and they're fine. They run away and everything's right with the world, right? They go about their business. But when a parent or an adult sees a kid fall down and they go, oh my God, oh my God, oh my God, what does the kid do? Then they start to cry or they start to freak out. So your reaction can directly impact your patient. So if you're freaking out because somebody can't breathe, it's going to freak out your patient. Additionally, what's one thing you should never say to somebody who's having anxiety issues?
Calm down.
Calm down is like the absolute worst thing you can say to someone because it's generally going to have the total opposite effect. So in an emergent situation, somebody not being able to breathe, yeah, it is terrifying. It is very, very scary. Like they could potentially die. So we have to make sure we control our face and we present ourselves in a calm manner. So try to help your voice. You know, if you have a really high squeaky voice, it may not be overly calming, you know, but just speak slow and kind of quiet. If therapeutic touch works for your patient, doesn't work for everyone, you know, just a light touch might be helpful, or just a calming presence can be great. Dimming the lights as much as possible, closing a door, trying to reduce external stimuli are all ways to kind of calm a situation, because the hospital's loud and noisy and lots going on, but just don't freak out yourself. And then we're going to dive more into the medications and education. Asthma is one of those things where there's not a perfect recipe for everyone. Depending on how bad somebody's asthma is, you could have 5 asthmatics all in a row. Every single one is on different meds and a different regimen, because their asthma is different and there's different triggers and things that work for one and not for the other. So there are some key takeaways though that we want you to understand. Long-acting medication or inhalers are great for preventing an asthma attack. We take them every day to reduce the risk of it happening. It works how it works. Every med is different, but we don't use them if you're having an acute attack. If you are having an asthma attack and you take one of the long-acting meds, it could potentially kill you. But long-acting medications are usually taken every day. So that's like your Qvar or Advair, something along those lines. We also have our LABAs, which are long-acting bronchodilators that can be taken every day. Our short-acting medications, like our albuterol, are very common, and that's what we give in an acute attack if they're having an issue with breathing. If your patient is on a long-acting medication and a short-acting medication, which one are we giving first?
The short acting.
The short-acting. The short-acting is going to open up those airways and areole, everything that we need to breathe. And then that long-acting will get absorbed to more, so it'll be more effective. That being said, not all asthmatics are on a long-acting medication. Maybe they have situational asthma or sports asthma, and they just need the short-acting to help them through things. It truly depends on what their regimen is. But if they are on both, know that you give the short first for that reason. If you are giving albuterol, we expect the heart rate to increase, and they get twitchy, especially with nebulizers and breathing treatments. They can get the shakes. So this is education that we'd want to provide to them. I will say, you will see in practice, the longer somebody's been asthmatic and more accustomed to albuterol, the less side effects you kind of notice in terms of like the shakiness. Or if it's like, but if it's like high doses or a lot of albuterol at once, you can see these things. So corticosteroids can also be given to help with the airway. And again, we want to watch things like blood sugar and that sort of thing. But there's a lot of different medications that can be used. And again, it truly depends on the type of asthma that they have. So, and what their insurance will pay for.
Will we need to know the names of the medications, like the long versus short and stuff?
I would say you should be able to recognize
what
what's
is long
versus
and what is
short.
short.
I mean, because really for short, you have albuterol and ipratropium, and that's it. Everything else is going to be long. I'm trying to think. We don't go into things like we don't go into the pharmacokinetics type thing, like with like cromolyn and knowing that it's a mast cell stabilizer. It'd be more like, okay, it's a long-acting medication, that sort of thing.
Thank you.
Inhaled corticosteroids, what do you need to make sure that a patient does afterwards? Throw
Rinse
up,
your
Ethan?
mouth.
Rinse the mouth. Ethan's like, I'm like, oh, you gotta puke? Yeah, rinse that mouth out. We don't want brush. Okay, so status asthmaticus. This is a life-threatening, scary asthma attack. With this, extreme wheezing, extreme respiratory distress. We would expect them to have that severe dyspnea, the wheezing that you can hear across the room without a stethoscope. With status asthmaticus, when the wheezing stops, or if the wheezing stops and you haven't even gotten to the point where you're able to do anything yet, the patient is close to respiratory failure. So, if we can give medications and the wheezing stops, that's one thing. But if we haven't done anything yet and all of a sudden you don't hear wheezing anymore, that's a bad thing. We would also, if we did ABGs, the patient would be in respiratory alkalosis. So we'd have labs consistent with that. In the event that this is going on, you would need to know that they're going to be on continuous nebulizers. Most nebulizers last between 7 and 10 minutes. A continuous nebulizer is enough medication for it to run for an hour. They are sitting there that whole time breathing it in. It's not even a handheld one. It's coming in on a mask. They're just sitting there breathing in that albuterol. They will also receive IV magnesium. Magnesium will help smooth the muscle and allow for breathing. And we need to prepare to be intubated, because in the event that some of this stuff doesn't work, we have to be ready to go. Other things that would be given: IV fluids, oxygen, bronchodilators, which is like your nebulizers, epinephrine potentially, and some systemic steroids. I can talk.
What exactly causes this? Is it just really, really bad asthma?
Mm-hmm.
Okay. So anybody can have it.
Uh-huh.
It just,
Yeah, usually I want to say the times that I've seen this, it's been severe triggers that have caused it, non-compliance with medication regimens, and it just causes everything to kind of poop out. But asthma is really scary, and it's not just a pediatric disease either, which I think people tend to forget about, especially as people get older. They're like, yeah, I had asthma as a kid, and they stop taking their inhalers, or it's a cost thing. Inhalers are expensive, so that puts them at high risk. Education. Smoking. I want to say a good amount of asthmatics know not to smoke, and they stay away from smoke, but there's some that don't. But also, it's not just the patient not smoking, the asthmatic patient, it's the family members. It's where they're going. Smoke is a very big trigger for asthmatics. And I've had patients say, well, I smoke outside. Great. Don't make your house stink. That's awesome. But it's stuck in your clothes. And then if you cuddle somebody, they can smell it, and it can become a trigger as well. So we really want people not to be smoking. It's also important for your patient to know what their triggers are. Again, no two asthmatics are the same. Some have severe issues with odor. I had a patient who asked me to leave their room because my Tide Pod scent on my scrubs was too much for them and causing respiratory issues. Like, I don't wear perfume to work, but just the soap scent or some people's deodorant can really trigger people. Seasonal allergies. I don't know what's going on in Utah, but pollen in Wisconsin is off the charts. Like, to the point I don't have allergies, but even I'm being bothered by it right now. So people that have sensitivities may be using their rescue inhalers more often than they were before, which is a sign that things are not going well. Stress can also trigger asthma. Stress can cue anxiety. We forget our relaxation techniques, and we can trigger ourselves into an attack. Also things like air pollutants and chemicals as well. Other education that needs to be done. People think that they know how to use their inhalers. I'm going to tell you at least 50% do not use them properly. Okay. The number one way to promote compliance and accurate usage of an inhaler is to use a spacer. Okay. Spacer's that clear plastic tube. The inhaler gets inserted. You put your mouth up against it and you inhale after you push down. If the spacer sings like a harmonica where you're inhaling too hard. We want them to slow it down a little bit. You might hear a little bit of noise, but it's meant to be a very slow inhale, okay? And it allows, the spacer allows for that and to not let medication escape. So you're getting a better dosage. What's the bad thing about a spacer? Well, it's not cool. Okay, it's harder to carry around in a purse or a bag or whatnot, because it's a little bit bigger. And it looks, some people have issues with the way that it looks because it makes me look like I'm really sick because people are vain. So they'll just use their inhaler on their own. The problem being, you know, they'll just go and they think that they're done. And that's not really how it works, is it? We know that we have to take slow, controlled breaths, hold our breath, let medication absorb, and then exhale. But people don't do that. We also have different kinds of inhalers, like the Advair, the dry powdered, where we just click it and we inhale, you know, making sure that they're doing that appropriately and then rinsing their mouth out afterwards. Other education that needs to be done is the importance to sticking to the regimen, okay? You shouldn't have to increase the use of your rescue inhaler. If you're using albuterol more often, something's not working. So you may need to change your meds. And a lot of it with asthma is going to be trial and error. But again, sticking with the regimen will help prevent attacks. I used to teach fundamentals at my last college. And I always like to show this video when we would talk about inhalers. Let me find that real quick. What tab did I have it up on? Here it is. All right. Who's watched House?
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, Anna, and you have to try it twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Joke. So that's one of my favorite clips. House generally does a lot of things wrong, but he did some good stuff here. What is an example of something that he did right or well?
Return demonstration.
Exactly. He said, why don't you show me how it works? And it was the right thing to do. And anything else? He bit his tongue. Do I look like an idiot? I mean, I know my sass sometimes is like, well, so he did very well. But return demonstration is a great teaching method that we should be utilizing more. Show me how to do this or how you would use that. It will help make sure that they're getting what they need. And you'd be surprised at the amount of people that can't do things properly. So, all right, let's go ahead here and do another polling question. All right, so how does asthma cause both hypocarbia and hypercarbia? And that's going to be A. Hypocarbia begins when they're hyperventilating and they're blowing off the CO2, and the hypercarbia happens when they start holding on to more and more and more. So, oops, I didn't show that, my bad, there you go. Okay, questions on asthma? Feeling good in the neighborhood? All right. COPD. So COPD is one of those diseases that you'll see a whole heck of a lot. The older, I don't know, I can't say that. It is generally a disease that affects older people. And I mean, I have not seen COPD in somebody in their 20s or 30s. I've seen the onsets in the 40s and then more 50s, 60s, and 70s. Okay, so it's generally not a disease you see in the younger adult. COPD is characterized by two diseases, and that's emphysema and chronic bronchitis. With emphysema, we have loss of the lung elasticity and hyperinflation. That's that increased compliance. And the alveoli are beginning to be destroyed as well. So we are not breathing as well as we should. We're holding on to more. We're not getting enough CO2 off. Chronic bronchitis is, I'm going to go out on a limb and say most of us have had bronchitis at some point in our lives. Usually a viral infection that causes, difficulty breathing and whatnot, and cough. Chronic bronchitis happens over time, usually due to exposure to irritants. Most common cause of COPD is smoking. However, there are plenty of people, large amounts of numbers, that have never smoked a day in their life and gotten COPD or even like lung cancer. So we don't want to just assume it was always smoking. It could be to their life. It could be due to the fact that their spouse smoked for 30 years. So we have to be careful. That's just throwing that out there. With COPD, one of the most common assessment findings that we're going to have is that dyspnea on exertion, shortness of breath with just even the smallest task. Getting dressed could cause them to have to sit down and breathe more effectively. But DOE is a big thing that we see. There'll also be a productive cough that'll be worse in the morning as everything settles. Low oxygen levels in the blood with the hypoxemia, crackles and wheezes in the lungs, shallow respirations because it's hard for them to take good breaths. Their lungs have hyperinflated and haven't shrunk back down, so it's hard to catch their breath. Long-term, been having issues with COPD for a long time, they'll have that barrel chest. That is that common finding. It doesn't happen right away. It happens over time. And they typically have a little thinner extremities. They're a little bit more frail looking aside from their big chest. We will also see dependent edema with our COPDers, and this is because of right-sided heart failure. And we go into heart failure in a couple weeks, but basically it's congestion. Everything comes from behind or flows backwards. So if there's an issue with the lungs, what's behind the lungs? The right side of the heart. So it's going to pull backwards and cause issues, and then we're going to see issues with dependent edema. So that's if your feet are sitting flat on the floor right now, and your feet are forced down on the floor, you're going to see swelling in your ankles and feet. Clubbing of fingers and toes, another one of those long-term expected findings that we would see. Low CO2 levels in the blood, and then paleness in the extremities or nail beds and mucous membranes. COPD patients tend to be some of the most anxious patients that you will care for. And it's because they can't breathe, and it makes a lot of sense. So calming techniques, breathing exercises can be extremely beneficial to these patients. This is a video about a woman's struggle with COPD that I think is pretty eye-opening. Hold on one second. I'm trying to skip it later.
If you struggle to lose weight, see this.
Let's skip that ad.
That I feel like I can take on the world. The breathing's not that bad. There's other days that no matter how much treatments I give myself, I just can't seem to catch my breath. It's like somebody put duct tape over your mouth and your nose and just cut a little hole and you're breathing through a straw. It's all I want to do is breathe. And something as simple as getting dressed just wears me out. It can take up to a half hour to get dressed, just putting on a simple t-shirt, pair of jeans, going to barbecues, having this fireplace lit. Can't do that anymore. It's very hard for me to go out and have a good time. I'm always afraid that if I laugh, I'll go into a coughing fit. Oh, the pain. I've lost out on a lot of what I used to do. I had always had shortness of breath, a chronic cough, and I'd get very tired with just any kind of little bit of exertion would make me very tired. And I went to doctors, and as usual, the doctors would say, well, if you lose a little bit of weight, you'll feel better. Cough never went away. The shortness of breath wasn't going away. The more I exercised, the worse I got. I went to my primary care and said, this is not working. He went and had me go for a spirometer test. And I thought, well, it can't be COPD. I don't smoke anymore. And I see how bad I am now compared to what I was last year. And I measure that usually by the holidays, by what I used to do and what I'm able to do. There's nights I can cook a meal. There's times that I can't. Boiling something as easy as a pot of water to make spaghetti. By the time I get the water from the sink to the stove, it can have me short of breath. This has all my stuff in it that I need for the week. I'm on a nebulizer twice a day. Oxygen whenever I do anything exerting. This is a medication I have to do 4 times in the morning, 4 times at night. The Spiriva I do once a day. My granddaughter is the one that's most vocal about something happening to me.
We used to go out and do everything together, but now it's like she can't do it. My biggest fear is losing her. I don't know what to do.
You okay?
My family's been so great with supporting me and helping me out. Emotionally, physically, I don't know how far I would have gotten. And how much more I'd want to keep pushing forward if it wasn't for them. Don't give up on yourself. And if there's shortness of breath, chronic cough, wheezing, exertion with a little bit of effort, there's a problem there. Go to your doctor and demand that he do a spirometer test. I have COPD, but it's not going to get me down. It's not going to ruin me. It might slow me down, but it won't get me down.
Okay, so I do like that. I don't like anybody demanding anything, but in that case, I don't like that word. But absolutely. So when she's talking about a spirometer, guys, that's the PFTs. So we can see what's going on with the lung functions. And I think this is a good example of bias, because most people will see someone a little chunky and say, well, if you lose weight, you'll feel better. And that is not always the case. So we have to take into consideration the extra requirements for time. If it's so difficult to get dressed and expending so much energy, and how exercise can be a task. Okay. To diagnose, or things that we would do with COPD, chest x-rays are definitely helpful, especially if we're concerned about infection or inflation of the lungs. And they can tell if they're hyperinflated or what's going on. ABGs are very common with our COPD or shocker because we know it's the most accurate test that we have to determine oxygenation assessment. We can also do things like blood cultures, sputum cultures, if we're trying to rule out infectious triggers of COPD, they're more at risk for other infections. So it might not just be their COPD, something else could be going on, triggering their breathing difficulties. So what are we going to do? Positioning is huge. These are patients we definitely want sitting upright. That tripod position, leaning forward, allows for that maximum lung expansion. High Fowlers. COPDers should not be laying flat. It makes it very difficult to breathe. I'm going to go out on a limb here and say there's probably a good number of you guys that have taken care of a patient and you walked into their room and they were sleeping in their recliner and preferred to sleep in their recliner versus their bed. I'm going to go out on a limb and say they probably had COPD. It's just easier to breathe when they're sitting upright. So definitely something that we would need to consider here. Eye cough, suctioning as needed, or other things that we could potentially be doing. With COPD, they will have an increased respiratory rate, meaning they're tachypnic. Do you know what one of the biggest lies in nursing is? Come on. No lies? There's no lies in nursing?
Respiratory rate.
Exactly. I would say that I think that's the biggest lie. For whatever reason, respiratory rate of 16 or 18 seems to be like it's the biggest lie. With someone with COPD, they're going to have a respiratory rate mid to high 20s, 30s, even higher. However, they will have a prolonged expiratory phase. They are working to breathe out that CO2. So we can expect them to breathe very slowly out. It's going to take a lot longer. Us, we're like, and we're fine. They are going to be blowing out a lot longer. We have to monitor for skin breakdown, especially if they are on any type of oxygenation or if they're not moving as well. If movement requires a lot of breathing or a lot of energy and tires them out, chances are they're not going to want to move as much, so they're at high risk for skin issues. Daily weights is another important thing, especially with our COPDers, and if we are concerned about right-sided heart failure. What are the key characteristics to a daily weight?
Same time, same scale, same clothes. Yeah.
Those are the big ones. In the hospital, it's kind of easy because they're usually just wearing a gown, and we want them standing. We know standing weights are the best weights every morning. If they're at home, I tell them, get up, go pee, get naked, stand on the scale. We want to weigh as little as possible generally. So like, let's take off all those extra factors, but just do it every morning. In terms of education, there's a lot that we're going to go into. Medications as well. There may also be chest physiotherapy that could be done. This is something that's usually done by RT. You may commonly associate this more with our cystic fibrosis patients. They'll wear a vest and it like shakes them to help break up secretions and help clear things. But they can do that with COPD as well, or they can like break things up with like their hands. But they're specially trained for that. So don't just start like nunchucking on your patient trying to break stuff up. They have to be trained for that. In terms of meds, they're similar to asthma. Bronchodilators are big ones to help with breathing. Inhaled corticosteroids as well. Anti-inflammatory meds. And then the big change that we added here is the mucolytic agents. It is not uncommon for our COPDers to need help clearing secretions because their lungs aren't working as well. So something like guaifenesin, aka Mucinex, can be given every day, or acetylcysteine, which is like the most disgusting medication on the planet. It smells so bad. It smells like pure rotten eggs. but really helps with breaking up secretions. With education, we have to kind of have a come to Jesus with people, okay? There is not a cure for COPD. It is something you are going to struggle with for the rest of your life. Additionally, our goal is to prevent it from getting worse and leading to heart failure, okay? But it's important that they understand that they are at risk for their heart beginning to fail because of their lungs failing. Other education that we can provide are assists. It may be difficult for people to do their ADLs, laundry, walking, taking out the garbage. They might need home help or a care worker, something to help with these things. Or like even cooking can take a lot of energy. So maybe something like Meals on Wheels can help. We can initiate that sort of thing, give them resources. Part of the education that we do as nurses is also helping with resources. Yes, case management help a lot as well, but we can fill in that gap too, because case managers are nurses. I don't know. I think cooking doesn't require the energy, but the dishes afterwards, that's the issue. High calorie diet. We want to increase their calories. They need a lot. They're expending more energy to breathe, so need calories to supplement that. We need to teach them about the importance of following through with their medications. Not smoking is going to be huge. Also, making sure that they are properly hydrated. All right. We want patients to have 2 to 3 liters of water a day. Remember that water helps thin secretions and makes it easier to expectorate. So we want to push fluids. It does get complicated if heart failure is involved and they have fluid restrictions, and we have to kind of be careful because they're holding on to fluids as well. But if that's not an issue, we want those fluids. We need to push them. Our eye cough, our vaccines, breathing techniques to help with that, even just positioning, that sort of thing. Pulmonary rehab is kind of like, it's rehab for your lungs. Like if you were to break your leg and need to go to physical therapy and do rehab for that, it's the same thing, but just helping with respiratory, monitoring their PFTs, exercising them a little bit to help prevent things. So that is also something that can be taught to the patient as an option. All right, so we have another polling question here. Oh, I never stopped sharing that one. My apologies. Okay, so which of these is not an expected finding of COPD? And that is going to be the shortened exhalation. We'll have a prolonged exhalation. Let me see something really quick. I want to make a decision real fast. Okay, we'll do one more disease and then we'll take a break. All right, TB. So TB is one of those diseases that I hope you never have to see. It is not as common anymore, especially as sanitation has improved, living conditions have improved. You guys have probably all seen like Ghost Adventures or something like that, where they're at an old TB ward. I mean, it killed millions and millions of people because it is so infectious and easily spread. It is a very dangerous disease. We do still see it. I will say in 10 years, I've seen it twice. And they're sick kittens. They'll be very, very sick. The important thing to understand about TB is how easily it's spread. That's why they wear the N95. We wear N95s if we're concerned about TB. But typically we again see it in poor living conditions, crowded areas, place where healthcare is not as easily accessible. With TB, there are certain symptoms where if you hear the grouping of them together, I want your brain to be like, crap, that sounds like TB. Okay. So the big things with TB is if they've had a cough, like a persistent cough, it is going on and on and on for more than 3 weeks. That's one of them. Night sweats is another very red flag for TB. And then a lot of sputum, possibly with some blood. So those are some of those big warning signs. In addition, they're going to be very tired, very lethargic because they're coughing, and you guys have had coughing fits and you're like afterwards, you're like, oh, I'm pooped. TB will also experience a lot of weight loss. And then interestingly enough, I cannot tell you why, they'll have a fever, but only in the afternoon. Don't know why. But if you take it in the morning, they'll be fine. And then the afternoon, they're going to have a little bit of a low-grade fever. So interesting. But cough, night sweats, think TB. With TB, detecting it early is important because it is so easily transmitted. If they are in a high-risk area or if they work in healthcare, they should be screened annually for TB. People can be exposed to TB, but they have not developed the active virus, but they can have what's called latent TB. So what happens is you get exposed to it, the TB bacteria is living in your lungs, and it encapsulates itself, and it's just chilling there, and it could be there for a very long time. You may or may not have symptoms with this, but all of a sudden something can happen and it becomes active. And then you're having all those coughs and weight loss and night sweats and all that sort of thing. So that's what they mean by latent TB. It's in the body, but it is not active. And usually that can happen just by being exposed to it. So with TB, we diagnose it through a couple of different ways. You guys have all had the intradermal test, the Mantow test. They take the little needle with the tuberculin, they insert it underneath the skin. We check it in 48 to 72 hours to see if you've been exposed. The Mantow PPD, the PPD test, is not confirmatory of you having TB. It means you've been exposed. So further testing would be required, AKA a chest x-ray. But it is the most common and easy test that we have to do. The QuantiFERON TB Gold is a blood test that we can do. It has a much quicker turnaround time, a little bit more expensive, but it is definitely something that we can do, and it will tell us if they have TB or not. The chest x-ray that gets ordered tells us if there's any active lesions of TB lesions in the lungs, basically if they're infectious or not. So if they have that positive Mantow test, they have to get a chest x-ray. Then they have to basically get cleared, saying, nope, they don't have it. Yes, they do have it. Go from there. We can also diagnose with some sputum cultures as well, early morning sputum. If, I'm going to say, I totally forgot what I was going to say.
Well, I was at clinical last week and I was in the ICU, and the doctor thought that there was a person that had TB and they had done all of those tests and everything was coming back negative. And he said that the final thing that he needed to do was a bronchoscopy, and the patient was refusing, but he said that would be his final determination to get like I think he was going to do a biopsy or something. But is that, so even the chest x-ray is not the final, like?
I guess it sounds, were the other labs negative?
Yeah.
And he was just still convinced that it was still TB?
Yeah.
I mean, I don't blame the patient for saying no. If everything's saying no, I guess I would be like, well, that these tests are pretty tried and true and would tell us. The bronch, they could biopsy it. It's pretty invasive to diagnose TB. And I would think it'd be pretty unlikely that they would have it and not have positive tests, but maybe there's something else going on too. I mean, they absolutely can, but again, it's pretty invasive compared to a blood test and an x-ray.
I just thought it was weird. I never heard that a bronchoscopy was even used to diagnose TB. So I thought it was interesting that he was so adamant that that's what he needed to do.
Well, what the bronch can do is pull out secretions. We can use it to remove secretions. So we would truly get a really great sample to culture versus trying to spit something up, which is pretty extreme. But again, not knowing how sick the patient was and things like that. So I guess in that sense, it would make sense. But again, not something most commonly done. So I had a patient who, I worked in a low income area, very urban area, at a federally qualified health center where everybody is either uninsured or underinsured. And at this time, I was primarily working in women's health. So I was assisting with pregnant ladies, teachings, education, helping with, yearly exams, that sort of thing. And I had a woman come in who ended up being positive for TB. And she was sitting in the waiting room with all these pregnant women and everything like that. And it was, that was a big mess. Oh, I remember what I was gonna say now. We don't vaccinate for TB in the United States. Other countries do. If your patient has ever received a TB vaccine because they lived outside of the US, their PPD test will pop up as positive. So that's an important question to kind of keep in the back of your mind. Be like, have you ever received this vaccine or lived somewhere, that sort of thing. In terms of interventions and caring for them, heated and humidified oxygen will be extremely important, and those airborne precautions, negative pressure room, N95 mask, and if the patient needs to leave their room for whatever reason, diagnostics, that sort of thing, they need to make sure that they're wearing a surgical mask when they're being transported. Additionally, making sure that they are receiving proper nutrition. They're not going to want to eat, but they need increased protein, helps with healing, iron, vitamins, that sort of thing. As I mentioned, it's a reportable disease. So when you work in a hospital, somebody will report to the health department and say, hey, this person tested positive for TB. And if you've ever been a part of this with COVID, they do the contract tracing where they're working backwards and say you were in contact with this person. They do the same thing with TB. And the health department will notify these patients or people that they could have been exposed to go get tested. Everyone who works in settings where they could be dealing with anything airborne need to be fit tested every year. So that's where they get tested for the proper size N95 mask. They get this little, they put their mask on, they put the hood on, and then they spray something. And if you taste it, it's the wrong size mask. If you lose a whole bunch of weight or have like massive facial surgery or dental surgery, you need to get refitted because you lose structure in your face and the mask might not fit as well anymore. If you are a bearded fella, you're probably going to wear something like a pepper, which is this big old mamba jamba right here, kind of like makes you look like something out of the CDC, like scary movie type stuff, like you don't want to breathe. But it's just an oxygenation apparatus to help with breathing. All right, meds. TB meds are extremely important, and it's important to understand them as a whole. TB meds patients take for 6 months to a year. It is a very long time frame that they're taking these medications. We take them at the same time every day, and it is extremely important that they take them because it runs the risk of the TB coming back. It is a hard virus infection to fight. There are 5 main TB drugs that go by the mnemonic RIPES, and every single one of them has a major side effect that you should know. So rifampicin will turn your secretions red, orange, your urine, your tears, your sweat. It is not uncommon to have stuff all over your bed when you wake up in the morning. Isoniazid causes peripheral neuritis. Pyrazidamide will increase uric acid. I don't know what you guys know about gout, but gout is a buildup of uric acid that affects like toes, joints, knees, and is extremely painful. Like the slightest touch hurts. So that medication can cause basically a gout attack. Ethambutol causes visual disturbances, like you can potentially go blind. And streptomycin is ototoxic. All of these are extremely hard on the liver, so we have to watch our LFTs. We also need to educate the patient and their families. If you notice any change in their skin color or in the sclera of their eyes, we're looking for jaundice. No drinking while we're on these meds. The meds and the alcohol together can destroy the liver and cause liver failure. So we need to scare some patients sometimes, like this is a big deal. So yeah, the medications they're on for a very long period of time. They aren't hospitalized for this long a period of time. They're not stuck in their house. Once they begin treatment, they're good to go. They should wear masks when they're in public, complete their treatment. And then again, anybody who's exposed prior to treatment should be tested, and just be on the lookout for any types of symptoms. So, questions on TB? I hope you never see it. All right, we are at 12:03. Let's go ahead and take our second break. Let's come back at 12:15. What do I want to hear?
time, another town, another everything. But it's always back to you. Stumble around in the night, in the pouring rain. Maybe the black sand thought is more I need. It's always back to you. While I'm
Okie dokie. Okie dokie, jokey. Nothing to mom jokes. All right, PEs. We're going to dive right back in. So actually, the next few things that we're going to talk about have the initials of P and E, which is interesting. But pulmonary embolism. So pulmonary embolisms can be potentially life-threatening emergencies. What happens with a PE? A clot forms somewhere else, almost always in the legs, and it travels to the lungs and it nestles there and just wreaks havoc on the rest of the body. So you need to know PEs, they start somewhere else. It's a clot that started somewhere else. Certain risk factors make people more prone to clots than others. We know this already, but we're going to review it because it's good information. Long-term immobility. If we're not moving, we're at high risk for developing DVTs. Being on the pill. Oral contraceptives put women at significant risk for developing a blood clot. Additionally, so does being pregnant. So does smoking. So does being obese. So if you are an obese woman on oral contraceptives who smokes, whoo, that's a lot of risk factors. Recent surgery puts people at risk for clots. Trauma, which surgery is a form of trauma, okay? Don't get it twisted. We are cutting up in the body, we're causing inflammatory responses and trauma, triggers the clotting cascade, which can put people at risk for clots. And we're not always as mobile after surgery either. Also, some medical conditions like heart failure or AFib put people at risk for developing clots and advanced age. So understand the risk factors. What do we expect to find with someone with a PE? If you ever see the term impending doom in a question, think PE. People that are experiencing pulmonary embolisms, they feel like something's wrong, something's going on. They can't put their finger on it, but they sense it. They may have a little bit of chest, I don't want to say pain, but tenderness. It hurts, like a pressure, because this clot is occluding the ability to the lungs to move. Shortness of breath, some bloody sputum, hemoptysis. We'll also have a high heart rate and low blood pressure. Additionally, we can see things like petechiae, which are these little red dots. They're little bursted capillaries. You'll see that on the chest. Some cyanosis. So a lot of different findings that we would see. I'm also going to tell you that not every PE is the same. Little tiny ones may not have as big of effect as a big massive PE that is occluding a whole lot and causing a lot of damage. However, they're all serious. They all need to be treated. Some people might have multiple little tiny ones, or some might have some big mamma jambas. It truly just depends. Regardless, we have to take it very, very seriously. Also, not all people that have PEs get hospitalized. Depending on the size, they can be put on oral medications and they go home and they're on their way. So it really does depend on the extent of the clot. To diagnose a PE, there's a lot of different things that we can do. So most commonly, if we are concerned about a PE, they're going to do imaging. They're going to do either a VQ scan or a CT-PE, or they can even do angiography, where they're going to take a little bit of a look around. But we need a good detailed visualization. A chest x-ray they can do, but it's not going to give us the same quality of imaging and detail as like a CT scan would. So those are all things that we can do. Blood work can also be done. A CBC could tell us what's going on with the number of platelets and puts them at risk. Or there's a lab called a D-dimer. A D-dimer tells us that there is a clot present, but that's all it tells us. So it's not overtly useful because we have no idea where said clot actually is, just that they are present. So it's helpful in a sense, but it doesn't give us enough information. It would require further testing to figure out where this is. And ABGs can be done, obviously, if we are concerned about respiratory status and what's going on with that. And we would expect a high CO2 level and potentially a low O2 level as well. Labs consistent with respiratory acidosis. When caring for someone with a PE, it is important that we are watching their respiratory status very, very carefully. We don't want them to stop breathing or having issues with oxygenation. We also need to be looking at their cardiac status. Are they perfusing? Typically with PEs, they're going to have low blood pressure, so we have to make sure that they're perfusing well. So we need to watch for those signs and change of level of consciousness. Is the brain getting enough oxygen, or is it low because of poor cardiac output, which is a significant issue with PEs? Also, we have to do medications. The gold standard for treating PEs are anticoagulants of some sort. We can do IV heparin, we can do subcutaneous enoxaparin, aka Lovenox, or oral warfarin, or a combination of those. So heparin, if we're treating a PE, they're going to get intravenous heparin. Subcutaneous heparin is used for prevention of clots. If we have a clot and they determine that they want them on IV heparin, that's what we would expect to see, okay? IV heparin, what labs do we monitor with IV heparin?
Your PTT and INR?
So heparin is your PTT. Your PT-INR is going to be warfarin.
Okay.
So heparin, we'd look at that lab specifically. We get it to a pretty place, we titrate it as needed, but we'd be evaluating that pretty frequently. Anytime we make a dose change, there's a lot of big protocols that go into place with heparin. It's a scary medication. Enoxaparin is, again, that subcutaneous anticoagulant that is weight-based. So you could give Lovenox to 3 different patients. Everybody's gonna have a different dose because everybody's a different weight. So it's more specific. And then warfarin, our oral med, we know we monitor PT-INR. We have to get to a therapeutic level, which would be between 2 and 3. And there's some diet restrictions that go with it. So every medication has their own pros and cons. Can you be on IV heparin and warfarin at the same time? Good, I see some yeses. We can. So if somebody needs to be anticoagulated, heparin will do it the quickest, right? Because it's intravenous, it's gonna act right away. Patients don't go home on IV warfarin or on IV heparin. They're gonna need something else. So it's called a bridge. So they'll get IV heparin, and then we'll start them on warfarin. Once the warfarin is therapeutic, then they'll stop the heparin. The reason we can do this is that they act on different parts in the clotting cascade. So yes, they're at high risk for bleeding, but they don't interact with each other in that sense. So it allows us for the patient to be coagulated the whole time. Because if we were to stop IV heparin and then start warfarin, it takes a couple days for the warfarin to get therapeutic. So we run the risk of the patient not being coagulated, which is a bad thing. Anticoagulants do not break up a clot. They make our platelets less sticky so the clot doesn't get bigger. The clot will start to dissolve and reabsorb into the body on its own. So that's what those meds do. Thrombolytic therapy, that's our alteplase or our TPA. This is our clot buster. This is a big daddy. This will get injected directly into an area to bust up a clot. We have significant bleeding risks associated with this that we're going to get into when we talk about like strokes and whatnot. But any of these medications, bleeding precautions need to be put into place. So if your patients are on these medications, what safety concerns are you concerned about and would you want to put into place?
Any bleeding risks?
Okay. What would you want to do?
I mean, just make sure they don't have any cuts or monitor their IVs or if they have like, I'm thinking of strokes, like you don't want to give them TPA if they have a hemorrhagic stroke or any peptic ulcers, something like that.
Okay. So if we are concerned about bleeding with anybody who's on an anticoagulant or a TPA, what are you going to look for and what are you going to do to keep them safe? Anyone?
You don't want to see a drop in their blood pressure. That means they might have a bleed.
Okay.
You don't want to be giving it to people that are high fall risk. And if they are, you want to keep them safe because that fall can make things way worse.
Okay.
Would you look for bruising?
Absolutely.
Would you want to have protamine and vitamin K ready?
How are we going to keep people safe? How do we prevent falls?
I'm gonna guess educate the patient.
Okay. Don't overthink it. What do we do as nurses or techs to help people not fall down and go boom?
Put the bed alarm on and tell them like, don't get out of bed without push for help.
Okay.
The non-slip socks.
Mm-hmm. Bed in the lowest position. Hourly rounding. Most people fall because they're trying to get out of bed because we don't check on them enough and they need something, right? And if somebody who has an unwitnessed fall, you always have to assume that they hit their head. Even if they say that they didn't, you cannot take that risk, especially if they are on any type of anticoagulants. We had a travel nurse once in the ER who had a patient who came in after a fall and did not inquire about, was it a witnessed fall, unwitnessed fall, and the patient was bleeding into their brain the entire time. And we didn't get that information from EMS, and it was catastrophic because she didn't assume that somebody hit their head. We have to assume the worst. If it's a witnessed fall and they said, no, they didn't hit their head, that's one thing, but people don't always know. So we have to be very, very careful. Again, grippy socks, bed in the lowest position, fall precautions, things within reach, well-lit things in the room. You know, we don't sleep with overhead lights on, but maybe we want a night light on. Easy access to the lights, call light within reach. If they need to shave, an electric razor, not anything with a blade. Watching soft bristled toothbrush, prevent injuries. You look at me funny, I bruise, and I have a tendency to walk into walls, so I should just be like a bubble wrap if I'm ever on anticoagulants, but preventing injury as best as we can. We know that there are some dietary considerations with warfarin. We don't make changes to their vitamin K. So we don't want to just suddenly, all of a sudden start eating spinach, but if we've been doing it, it's not so much of an issue. Know what vitamin K, what foods have vitamin K? Dark leafy green vegetables. That's not iceberg lettuce or celery, you know, that sort of stuff. So diet education is important with this. Other things that we can expect to be done with PEs, potentially. One thing that they could do is an embolectomy, where they're going to go in and they're going to remove the clot. This is a beautiful clot. Like this is like was part of like the tree in the lungs, and you can see its shape. Like that's pretty awesome. This person was probably in a very, very bad way. Not all clots look like that. They might just be like this. A vena cava filter. This is an IVC filter. If you've ever heard that term thrown around, they go in and they put this little teeny tiny metal cage like thing into the inferior vena cava. So if somebody has a clot in their leg, it doesn't go to the lungs. It's like a stop. and it'll collect it and it'll just reabsorb back into the bloodstream and go away. But it prevents clots from getting to the lungs. So people that are very prone to clots can have these placed. Or if there is a concern of it dislodging, they'll throw these in. The big things I want you to take away is, how do we care for them? What safety concerns, what teachings? And that has to do with safety, meds, treatment when we're talking about these diseases. So what would you want to know? What's the worst that could happen? That sort of thing. So in terms of education, not smoking is a big one. And it's not because smoking is bad for you. We know it's bad for you, but smoking constricts your blood vessels. It puts you at higher risk for developing a PE or a clot in general. We also want to promote movement. All those risk factors we want to prevent. So we have to change what we can. Compression stockings, SCDs, staying hydrated. Hydration means our blood vessels are nice and open and bouncy, whereas when you're dry, it's harder to, your veins are like, they don't stick out as well, and they're going to collapse a little bit more, making it more likely for a clot to form. And then we talked about the warfarin. So again, with PEs, generally, I'm going to say 90% of the time, it's going to start as like a clot that happened in the leg, and it makes its way to the lungs. Okay. Polling question. All right. A few more seconds here. Okay, so where does a pulmonary embolus begin forming? And that is going to be as a DVT in the leg. It's not going to start in the pulmonary vasculature. Only where there has been trauma. Trauma increases that risk, but only, that makes it wrong because we never use only. Okay, and same thing with only in angiography. It has the word only, so that means it's wrong. But angiography is not going to tell us where it started, only where it is right now. All right. Anything else on PEs? All right, so now let's get into chest trauma, chest injuries with the lungs. So we have a couple different kinds of chest traumas that can occur. A pneumothorax is when we have air or gas in the pleural space that causes the lung to collapse. A hemothorax is when we have blood in the pleural space, not allowing for anything to work. And then a tension pneumothorax is when air is going to get into that pleural space and isn't able to get out when we breathe. And then that air that gets stuck causes issues with the heart and the lung, which prevents cardiac output from happening and can result in death. Tension pneumos are very, very serious. They're all serious. Don't take that the wrong way, but tension pneumos we need to fix immediately because of the cardiac involvement that occurs. So with the pneumothorax, again, it's understanding what is what with these. And if you know your first part of it, you're good to go. So again, tension, air enters that cannot get out. It increases intrathoracic pressure, which compromises cardiac output. which means the rest of the body is not getting blood that it should. With a hemothorax, we have blood, most common after a trauma, an accident, even surgery that this occurs. A pleural effusion is basically pleural fluid in the pleural space, preventing the lung from really moving, but can compromise cardiac output as well. And then an open pneumothorax is when we have an open wound that is causing causing the lung to collapse. So we need to cover the hole. So it needs a penetrating wound for that to occur. Risk factors for pneumothorax: injury, blunt force trauma to the chest wounds like being shot or stabbed, or a chest tube can actually cause a pneumothorax. If the chest tube gets pinched or occluded or clamped and it's not supposed to be, it can cause the lung to collapse. COPD patients are also at risk for this happening as well. And then we have something called a spontaneous pneumothorax. This happens primarily with teenage, tall white boys. If the patient goes from like 5'4" to like 6 feet in a matter of like 6 months, they grew very, very quickly, something happens that causes their lung to collapse. I've taken care of this a few times, but usually they have a really big growth spurt in a short amount of time. It puts them at risk for developing this. And there's really no symptoms except for all of a sudden they can't breathe. It comes out of nowhere. There's no precipitating factors aside from them growing a little bit or a lot very quickly. And there's nothing you can do to prevent those. So with these types of chest trauma, we expect issues with anxiety, inability to breathe, and some pleuritic chest pain. So it's like you're having some pain, but it's not chest pressure. It's not like in the heart, in the centralized chest. It's just like this burning pain kind of all over the chest. We will see signs of respiratory distress, low pulse ox, intercostal retractions, tachypnea, because they're trying to work to breathe. We will also see, depending on the type of injury that they have, tracheal deviation. So the trachea is going to move based off of where the injury or what kind of injury it is. With a tension pneumo, you are going to see the trachea move to the unaffected side. So if I have a tension pneumo on my right lung or my right side, my trachea is going to shift to the left. I have this buildup of pressure and it's forcing it out the opposite way. It's trying to move everything. With an open pneumothorax, I have an open wound. The trachea is going to get pulled with that side. So if I have a big gaping wound on my right side, I can expect the trachea to get moved because it's pulling out that way. We will not have lung sounds on the affected side, but that is collapsed. No air is moving. The lung ain't working. We can't, when we listen to lung sounds, we're listening to air move. And if there's no lung to move, you're not going to have sound. And then we can potentially see some subcutaneous emphysema with the pneumothorax as well. Air gets trapped in that subcutaneous tissue. So you can see here the trachea moves to the unaffected side if it was open, and then if it was a tension pneumo, the unaffected side moves over. So with these, we want ABGs are an expected thing. Okay, pretty much anything respiratory, think ABGs. Chest x-ray as well. Again, we don't test you on can you identify things on an x-ray, but here you can see a lung and here you see nothing. So this is an indication, this is not how it should look. You should be able to look and say, well, that's not right. If this is occurring, we can do a couple of things, either a thoracentesis or a chest tube. You would just assist. You never have to determine one over the other. There's a preference for a reason. The thoracentesis will go and remove fluid, especially for pleural effusions, whereas a chest tube will remove gas or air. especially if it's like a hemothorax or some type of trauma. So in regards to what you're going to do for these patients. So if you've never seen a chest tube inserted into somebody, there you go. It is violent. There's a lot of bruising, a lot of swelling that can go on. But we want to make sure that we are assessing their heart and lung sounds at least every 4 hours. They should be in a high Fowler's position because it's easier to breathe. And we need to be looking at that chest tube if it's present, looking at the drainage, looking at the site, looking for signs and symptoms of infection. Also making sure that we're giving medications. Benzodiazepines help with reducing anxiety. They also help like calm you down and breathe a little bit better, okay? Again, opioids may also be given, especially with our trauma patients, because they don't be in a lot of pain, okay? We use cautiously together, but we can absolutely give the two. We just have to make sure that we're assessing and watching, okay? So, education. After this occurs, you need to rest. It's going to take a while for the lung to recover. Even after we reinflate it, even after the chest tube's out and you're back at home, it's going to take some time for you to get back to your normal activity levels. Hand hygiene, immunizations are also very important. We don't want you to get sick, okay? Upper respiratory infections or anytime you're coughing and not feeling well increases intrathoracic pressure. If you're constantly sick or doing things like that, it puts a big toll on your chest and you run the risk of it collapsing again. This is a long recovery process. It takes weeks, months to recover after a collapsed lung. So this is important that you're not just going to be back to where you were at baseline right away. And then not smoking, shocker, and making sure that if they get sick, if they're coughing a lot, if they're having sharp chest pain, to seek help. Go get checked out to make sure that nothing else happens. We don't want you to lose the lung again. All right. So a lot of pulmonary issues have the initials of PE. So pleural effusion is like a pneumothorax, but with pleural fluid. So we have a lot of fluid in the space that's basically compressing the lung, and the lung is not able to move. It's kind of like, you ever try to run in a pool? Like you're trying to move, like you're working through water and it's just like you're in slow motion. Or if you ever try to like exercise on sand, it's a lot more work. It's the same thing with a pleural effusion. Your lung is trying to move and do things, but the water, the fluid, is preventing it from doing what it's supposed to do. Pulmonary edema is another condition that happens basically, fluid gets into those alveoli. So it's like pneumonia, but it's pleural fluid. It's not infection, but pleural fluid that causes drowning. We usually see this with heart failure patients, okay? And then our pulmonary embolism is going to be your blood clot in the lung. Flail chest is another complication that you may see. And what flail chest is, it occurs after a trauma, like a baseball bat to the ribs, a car accident. But what happens is you have multiple breaks in multiple ribs. So you have a big chunk. So here you can see in A, you have a break, 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 break. This would require surgical intervention because typically with broken ribs, we don't do a whole lot. We splint, we watch, and that's it. But with flail chest, you're at risk for all those pieces coming apart. And this is a very serious injury. So the chest wall is no longer stable. Whereas one broken rib, or you could have multiple broken ribs, but because it's in multiple spots in that same rib is a concern versus cracked ribs wherever else. Not trying to downplay cracked ribs because I know they hurt, but but this is a medical emergency. with flail chest, we'd want to make sure that they're getting oxygen, pain control, assessing lung sounds, and being prepared to get them either to surgery or ventilated, because we want to reduce the workload with that. All right, polling questions. There we go. All right, so difference between a pneumo and a hemothorax. A hemothorax is a type of pneumothorax filled with blood. Good job with that. All right, so now we're going to dive into respiratory failure. So this may get a little bit confusing, so I hope that I can button this up for you pretty nicely. So respiratory failure can happen for any reason. But basically what happens with acute respiratory failure is that the body can't oxygenate or ventilate, meaning movement of air, well, for whatever reason. Sometimes it's an illness, sometimes it's an injury, or it's caused by something else. So acute respiratory failure could be serious. We could just be having low pulse ox, and that's the secondary diagnosis. They may or may not need to be intubated. That's what PEEP means. Acute respiratory distress syndrome, or ARDS. This is bad, okay? And I know it gets confusing because you're like, well, failure sounds worse than distress. ARDS is worse. What happens with ARDS is that the alveoli collapse. We are not moving, and we're not moving air. They're sunk down, nothing's happening. We will give oxygen because their oxygen levels are low, and despite how much oxygen we're giving them, they're not improving. Their pulse ox is still in the toilet. So these patients, they need to be intubated. So with acute respiratory distress patients, they need to be tubed. This has a very, very high mortality rate too. 60% is a significant mortality rate. So we want to prevent things from getting that. Acute respiratory failure could lead to ARDS. Certain types of surgeries or comorbidities can lead to ARDS. But what happens again, we can't breathe, the alveoli collapse, they lost the ability to inflate themselves. So PEEP is what is used in ventilation. So PEEP is positive and expiratory pressure. We breathe in, we breathe out. They move up, they move down. In a healthy person, PEEP is how much pressure, alveoli pressure, above atmospheric pressure, that exists when we exhale. Okay, so it has to do with science. Air in, air outside, keeping things inflated. This prevents the alveoli from collapsing. There's two kinds of PEEP. There's extrinsic and there's intrinsic. Intrinsic is what's happening with you right now. It's happening when you breathe. Your neurological system is telling your body it's time to stop exhaling, and it prevents the alveoli from collapsing. Extrinsic PEEP is the ventilator doing it for you. So when patients are really, really sick, like with ARDS, they lose the neurological reaction to breathe normally, and they're at risk for that alveolar collapse. So something isn't connecting anymore. That PEEP forces it open for them to breathe normally. So with sick patients, the more likely you are for those alveoli to collapse. When they're ventilated, a little bit of air is left in the alveoli so they don't collapse all the way together. And then they move and move, move and move. The more gas exchange means that more oxygen is getting to the tissues, which means we have less acidosis and less ischemia. So basically, if your patient is ventilated, they're getting PEEP. Okay. Respiratory patients may need it, they may not, unless they're an ARDS patient, and then they absolutely need to be intubated. So, whew, okay. Acute respiratory syndrome, SARS, viral infection, mutated cold virus that used to not be so common in the United States. Clearly, that's not the case anymore. With respiratory failure, we expect certain findings with either ARF or ARDS. With ARF, we're going to have that dyspnea, but we're also going to have orthopnea. What does orthopnea mean?
Is it increased work of breathing?
Specifically, because why?
No, it's when you're supine, you can't breathe very well, right?
So orthopnea is like you can't breathe when you're laying down, but it's better when you're sitting up or standing. Okay. So it's basically it's positional breathing. We'll have that with acute respiratory failures. They need to be in certain positions to breathe well. They'll also be pale and cyanotic, hypoxic, hypercarbic, so high CO2, high heart rate, makes sense, they can't breathe well. There's also confusion. We're not oxygenating well and so we're not getting good blood flow, good oxygenated blood to the brain, so we expect the confusion. And then some agitation and restlessness. People that are hypoxic will get really, really squirrely. And they'll also have adventitious breath sounds. Adventitious breath sounds is a great adjective for saying this ain't normal, but I don't exactly know what it is. So if you're listening to a patient and you're like, I don't know if these are crackles, rails, whatever, rhonchi, if you use the term adventitious, you're golden. It just means it's not normal. With ARDS, we're going to have the dyspnea, but there'll also be pulmonary edema, meaning we're going to have that fluid in the lungs. The lungs are not complying well because the fluid is preventing them from working the way that they should. They'll be severely hypoxic despite their oxygen therapies. That is a dead giveaway of ARDS. So they could be on 15 liters, 100% oxygen on a non-rebreather, and their SpO2 is still 60, no matter what we're doing. They'll be very confused if they're even awake, and then crappy lung sounds. So diagnostics that we would do is a chest x-ray, ABGs, an EKG, because we want to make sure that the heart isn't involved, and then something called hemodynamic monitoring, which is basically a catheter that we put into the right side of the heart. And it's going to help us figure out what's going on with the pulmonary artery. So with respiratory failure, assessing lung sounds is going to be a big thing that we do, watching their vital signs, watching their ability to breathe, giving medications as ordered, whatever medications that they may be on, antibiotics, inhalers, that sort of thing. We also need to be on the lookout for the big, bad, scary things that can happen, like pneumonia if they are on a ventilator, repositioning them. In terms of respiratory failure, not ARDS, but respiratory failure, especially if it's an acute issue, if we treat the cause, we can treat the failure, okay? If an infection is causing somebody not to be able to breathe and oxygenate well, if we treat that infection, they breathe better. If they're heart failure, we can't cure heart failure, but we can treat it. If we get fluids under control, we can fix that respiratory failure. With drugs, taking high amounts of narcotics or heroin depresses the respiratory drive. If we reverse that, we fix the failure. We have to be on the lookout that it is very likely, not very likely, possible that patients with respiratory failure will need to be tubed. ARDS always will. The meds that we give for respiratory failure can vary depending on the cause. Benzos can be given to help with anxiety, to reduce the work of breathing. If they are tachypnic, we want to slow them down a little bit. We can calm them down. Benzos are great for that. Again, we do need to be careful when we're giving with opioids. Opioids will decrease respirations, but if they need the pain medication, they need the pain medication. We just have to make sure we're assessing. If they need general anesthesia because they're being intubated, propofol is one of those meds that can be given for that. A RAS score is simply a screening tool that we use to determine somebody's sleepiness, okay? You don't need to know anything more than that unless you get into giving anesthesia. You get properly trained. It's just a screening tool that we use. Corticosteroids help with inflammation. We can be giving that. And then vecuronium can be used to help sedate, paralyze. And then antibiotics if it's infectious in nature. Vancomycin is one of the antibiotics we give for a lot of respiratory infections because it is very, very effective. But with Vanco, we have something called peaks and troughs. So we do blood draws to see what the level of Vanco is within the blood, and it can determine the next dosage. So being aware that that's one of those meds that would require that. So we don't want to give the next dose until we have the blood work from the previous peaks and trough. Also with Vanco, make sure that the infusion rate is correct. If we give Vanco too fast, it turns somebody red. I've seen it. It's funny, but it's not funny. I mean, they're red, like Crayola crayon red. All right. All right, so what are we going to do with acute ARDS? Respiratory distress syndrome. 100% absolutely positively they are going to be mechanically ventilated. So CPAP really isn't going to do too much for anybody unless they have sleep apnea. BiPAP could be used, but it's not the best answer here because they need to be tubed, point blank. And a Venturi mask could be used, but at the same time, it's not going to do anything. They need to be ventilated. They need that pressure from that. So 100% we have to have them intubated. Okay, smoking. Any questions on that stuff yet?
I just had a question, like, if there's a trauma out in the field and like a patient gets stabbed in their lung, how long do they have until they get to the hospital to get like a chest tube? Like, is the paramedic putting something there, or are they bagging them the whole way there, or?
They will cover the wound, apply pressure, and probably oxygenate them. Unless it's like an advanced unit, they could possibly intubate them, but they're not going to intubate unless they absolutely need to. So the chest tube won't get placed until they're at the hospital. Stabbings are difficult too, because knives are crazy. Like certain blades can cause a lot more damage than others. And especially, you know, if you go in like this, okay, cool, we got good approximation probably, but when people twist and it turns and cuts things more, now I'm teaching you guys how to hurt someone, it causes a lot more damage. So yeah, stab wounds are brutal. And it's women stab, just so you guys know. At least in Milwaukee women stab. I mean, they shoot too, but generally when there's a stabbing, a woman did it to a man. Or another woman because she was with their man. Yeah, it's great. That's why I love the ER. I really do. It's a fun place. All right, so a few other respiratory disorders that don't have any like great place to put them, so we kind of grouped them together. First one is sleep apnea. We talked about this briefly last week. This is an obstruction that happens when we're sleeping and it causes you not to breathe. Why is that an issue? Well, you're not breathing. You'll lose the ability to breathe for at least 10 seconds or more, multiple times an hour. This is an issue because you're not oxygenating, which means your brain isn't going to get oxygenation. So typically people with COPD that don't wear their CPAP will be very, very tired. They're not going to have a great memory. They don't feel rested, and they're just kind of off. So something to think about and why treatment is so important. The biggest risk factors for sleep apnea are being obese males. So if we have an increased truncal obesity and an increased neck girth, that really puts a lot of restraint. Can women get sleep apnea? 100%. Men are just more likely. Usually this is undiagnosed until their partner says, hey, you need to go get checked out. If we don't treat sleep apnea, it can lead to high blood pressure, a heart attack, a stroke, and death. So what we do with with sleep apnea, OSA, is they wear their CPAP, they sleep position-wise, they might have to be up a little bit. We encourage them to lose weight because we want to remove as much of that extra fatty tissue from the airway as possible. And then there's also something called a mandibular assistive device, which is basically a way to force the jaw open to prevent stuff from going backwards from where it's going to occlude the airway. So yeah, we want to teach patients, hey, wear your CPAP. If it doesn't fit, let's get you fitted for a new one. This absolutely can kill you. So this is a nice little example. Here's your tongue and here's your airway. And with sleep apnea, it just pushes this through, and look at, there's no air going to be able to get through from the nose airway down to the rest. So it's occluded, obstructive. Epistaxis, a nosebleed. I know it sounds like kind of like, okay, everybody gets nosebleeds, and it's true, but nosebleed is we're having hemorrhaging from the nose. Things that put people at risk for a nosebleed is being dehydrated. Dry mucous membranes are more friable and easily damaged and likely to bleed. High blood pressure, bleeding disorders, hemophilia are at risk for nosebleeds. Using anticoagulants, being on aspirin, any type of trauma, or the people that really like to utilize nose candy, like sniffing and like drugs. They're at high risk for nosebleeds. So with nosebleeds, if somebody has a nosebleed, we want them to apply direct pressure to their nose, the bridge of their nose, and we want them to lean forward. I think we all grew up where we're like, oh yeah, tilt your head back, right? Don't tilt your head back. We want them to lean forward. Blood is very, very caustic. So if we're tilting our head back, the way everything is connected, you're going to swallow blood, which can upset the stomach and lead to a whole other fun issues of just not feeling good and that sort of thing. So lean forward, drip it everywhere else. I think parents tell them to drip their head back so they don't get blood everywhere, but forward. Typically, pressure and ice are really great at taking care of it. With more severe bleeds, they may require more tools, okay? So one thing that we can do is we can pack the nose. So we can use a rhino rocket, which is a tampon, basically, stuffed into the nose. They're a little bit smaller to help apply pressure and stop the bleeding, or they can use a type of balloon. In your first aid kit, always have a tampon in the event somebody gets a bloody nose. Stick it up there and just leave it and let that work. If that doesn't work, tamponading the bleed, they can do cautery, where they'll basically like singe things shut, or use silver nitrate to kind of stop the bleeding. And then we also, some places will use cocaine. Yes, cocaine. to stop a nosebleed. It vasoconstricts and causes the bleeding to stop. So you can't just go to your ER Med Select and grab cocaine and go from there. It's very controlled, but they can use it to stop bleeding in severe cases. What we need to look, our goal is to stop the bleeding, keep them calm, because blood is scary, and watch for any signs of hypovolemia, especially if they are on anticoagulants. They can lose a lot of blood volume pretty quickly. So
Why wouldn't they just use like norepinephrine or something?
it depends. They can do many different things, but
Okay.
they can use cocaine.
Question for you.
Yeah.
So my husband gets really bad nosebleeds, and there's been a handful of times where we've had to take him to the ER because it just doesn't stop. But the ER doctors actually told us, he's like, if you notice like it's won't stop, he told us to use Afrin.
Like the spray. The spray will have like vasoconstrict, but I don't, and they give it to people when they go home. I guess I don't understand.
I don't either. That's why I was asking, because it's like, and it's only happened a handful of times where he like it's hours of just bleeding, and it's getting to the point where he's kind of getting dizzy, and so we're like, okay, ER. But the couple times that we've gone when he's been leaving, they're like, yeah, do Afrin to kind of help. We're like, to help it stop. So just wondering.
We give it to patients after nosebleeds to help with keeping things moist. I'm sorry, I used the M word, to keep things like moist, you know, but yeah, I'm not sure how it would like stop a nosebleed.
Yeah, kind of interesting.
My daughter gets bad nosebleeds, but partly that's my fault because I've smacked her in the face with a soccer ball a few times. It happens. Don't use your face, use your body. It's not intentional. I'm not abusing my child. Please don't report me. Yeah. Some people are just more prone to nosebleeds than others. It has to just do with the face and the nose and the structure. So, speaking of noses, broken noses. So broken noses occur due to a trauma to the face. It will present itself after getting hit with pain and bleeding. There'll be some swelling. You'll probably see some type of deformity where the nose is like now crooked, and may even some black eyes because it's all like pressure here and whatnot. Nose fractures, for the most part, aren't always the worst thing in the world unless we are noticing some certain findings. Okay, so the nose is very close to the brain. Okay, the nasal bone. So depending on the break, we run the risk of the cribriform plate being fractured, which is going to separate the CFF from like your nose. So if there is clear liquid coming out of a nose after a break, there is concern that something happened to that, and that could be CSF. Or it could be boogers. You just got hit in the face. So we have to determine if it's one or the other. The way that we can do that is by testing it for glucose. CSF has glucose in it, our mucus does not. So that's something that we would be on the lookout for. But if you're caring for someone and you're seeing clear fluid, or you're at a baseball game and you're seeing those things to consider. And you can check for glucose, like with a glucometer. Somebody who's diabetic, you could put glucose CSF like on a glucometer, and it'll tell you what the blood sugar is. And if it doesn't report anything or says error, then it's not. So in the event that it's just a broken nose, I use that term lightly, we want to ice it, keep them elevated, check for bleeding, monitor their bleeding, making sure that we're just controlling pain. And no extreme sports, no balls near their face. And there goes your social life, Amber. Anybody know what that's from? Haley laughed. I think she knew. It's from Clueless. No extreme sports for 6 weeks. We want to protect the nose. What sucks about a broken nose is that unless your breathing is impaired, it is considered cosmetic surgery to get a rhinoplasty. So if you're breathing fine, but your nose is like wonky like this, or a big old honker like this, It's elective, it's cosmetic. But if you can't breathe and there's issues with that, then they would actually pay for it. So it can get tricky, very, very tricky. Let's see. Pulmonary hypertension. I touched on this briefly. We go more into this in the next few weeks. But what happens with pulmonary hypertension is that the pulmonary artery pressure is higher. We can't diagnose pulmonary hypertension without a cardiac cath, which we're going to get into in the next few weeks. But basically, there'll be a change in cardiac output and poor oxygenation because the pressure in the pulmonary artery is so high. Again, there aren't too many overt symptoms with this, but we'll talk about it more in the next few weeks. So I don't want you to focus on it too much, aside from right now knowing that it's the pulmonary artery that has a high blood pressure. We can take a blood pressure with our arm and we know that we're hypertensive, but with pulmonary hypertension, it's a lot more invasive to check for it. So signs and symptoms that pulmonary hypertension would be going on is really, it's a lot of cardiac output stuff. Blue lips and skin because we're not oxygenating well, shortness of breath, we're tired, there can be weight gain, a dry cough. Basically, the lungs are not getting what they need anymore and pushing out to the rest of the body. There is treatment for pulmonary hypertension. We can give meds to reduce the workload of the heart, which is what antihypertensive and DIG do. But the really only cure we would have is a lung transplant. So this is serious. We diagnose it, like I said, with the right heart cath and an echo, which we'll go into in the next few weeks. We usually don't see pulmonary hypertension until it's really late. But shortness of breath is going to be your main symptom. And then we'll treat it with meds, and then hopefully you don't die. Patients that are high risk for pulmonary hypertension are patients with COPD, pulmonary embolism, congenital heart defects, or mitral valve disorders. So our PE patients are at high risk for this. And polling question, last one. Alrighty, so your patient has acute respiratory failure. They are intubated and transferred to the ICU. What trauma? What should we monitor closely? All right, so coping. Coping isn't something we're going to monitor too closely, mostly because they're intubated and then recent trauma, that's not going to work as well as some of the other options. Level of consciousness, we absolutely want to monitor. Oral intake, they're intubated. IV intake, sure, but oral intake, they have a tube down their throat. They're not going to have any. And then ABGs and vital signs. So B, D, and E are your best answers here. And that takes care of that. What questions do you have? What's not clear? What doesn't make sense? What can I help you with?
Is exam 1 on weeks 1 and 2?
Yes.
Okay. And then you didn't confirm, or maybe I misheard when the exam review is.
It's not set in stone yet. I'm waiting to hear back from one other person, but it's gonna be next week.
Okay, cool.
Don't have the time. I'm waiting, honestly, I'm waiting to see if I have a conflict with my kids, because it's gonna be in the evening. So I'm just waiting to hear back from a coach, and then I'll post it probably tomorrow.
Will
Okay.
it be recorded and have it?
Yes.
Okay.
Yep. And then I will upload this recording once once Zoom processes it. So if you subscribe to the YouTube, you'll get the alert quicker than anything else. I don't want to blow up announcements every day, like posting the recording. So it's a lot easier if you just go about it that way. But yeah, I can post if you guys want me to. I guess it's kind of up to you guys. I know when there's a lot of announcements, you tend not to read them, is the issue. Like information overload. So I try to prevent that as much as possible. Anything else? Otherwise, that's all I got. Reach out if you need help, office hours. If those don't work, shoot me a message, let me know. Otherwise, have a good rest of your day.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.